positive impacts we are seeing from social distancing, and an overview of the crisis of care standards that were adopted yesterday by the governor's expert emergency epidemic response committee. Next slide. Joining me today will be state epidemiologist, Dr. Rachel Herlihy, and the department's chief medical officer, Dr. Eric Brandt. Next slide. So quickly, just a word on masks. I want to talk about the importance of wearing non-medical masks, as Governor Polis asked us to do last week. It's really important to wear them to protect others whenever you need to leave the home for essential activities, including even when you're out walking your dog or visiting a park. My husband and I are wearing our ski masks around when we're going outside. But this is really because we know the virus can be spread by people who are asymptomatic or have a mild case. So these offer an additional layer of protection. We are asking the public, please, please, please do not go out and buy surgical masks. Save those for our healthcare workers and our first responders. You can go online to the Colorado Mask Project and buy a mask, or use a bandana and scarf, or make a mask. And you don't have to be able to sew or spend a lot of money to have a face covering. And if you Google CDC cloth face coverings, that will provide some good guidelines. Next slide, please. So this just shows that the virus is affecting most of the counties in Colorado. You can see this is counties with confirmed cases and counties with no confirmed cases. It doesn't necessarily mean there aren't cases in those counties. It just means that we haven't detected them through testing and surveillance. And these are the data I will show are data as of this afternoon. They're preliminary data, but they're the most updated data that we have from today. Next slide. So today our numbers increased with 222 new positive cases for a cumulative total of 5,172 cases. We have 52 new hospitalizations for a cumulative total of 976 hospitalizations. And I'm sad to report we lost 8 people today for a cumulative death toll of 148 people. Next slide, please. Next, I want to talk about the incidence of this disease, and the partners at the School of Public Health estimate that COVID-19 testing and surveillance is only capturing about 28% of people who are symptomatic. So this is a more accurate count of illnesses, and everybody knows that testing supplies are in strong demand, but short supply. And so, of course, not everyone who's symptomatic is able to get a test. So from the School of Public Health, their estimates show that around 17,000 to 18,000 Coloradans have had COVID-19 illness. So this is more than we've been talking about with just the number of positive tests. This also doesn't take into account potential asymptomatic transmission. If there's a bright side to this, it's that the more people are recovering or will recover soon based on our understanding of other coronaviruses. They should have immunity. But at the same time, it's important to remember that Colorado has a population of nearly 5.7 million people. So we are still at the beginning of this epidemic. But these numbers do indicate widespread community transmission within the state. And we are starting to see signs of stress on the healthcare system. So the demand for hospital beds has been increasing. The state of Colorado has been working in partnership with local hospitals to support their ability to keep up with the demand. As folks have heard, there's a lack of personal protective equipment that healthcare workers need to protect themselves. And in a minute, Dr. France will talk about the current need to implement crisis standards of care around their use. We know the sickest COVID-19 patients need intensive medical care and have longer hospital stays, many requiring the use of ventilators to breathe. So these are the indicators that have really driven our work to get crisis standards of care in place. But this is also the reason that physical distancing measures are so important. Next slide. So I want to talk about how stay-at-home is working, and Dr. Herlihy will provide some more information and models in her presentation, but really from the beginning of the epidemic in Colorado, the physical distancing measures like the stay-at-home order have been done with an eye towards slowing the spread of the disease to a level that prevents the hospital systems from becoming overwhelmed. And this is really our North Star. Having the majority of residents staying at home not only slows the spread, but also buys precious time to get the healthcare system ready to meet the demand. I want to acknowledge that the Colorado Department of Public Health and Environment has been using Colorado's School of Public Health to create models that help inform the success of our physical distancing measures and also estimate when medical surge demand may occur. And we are so grateful for their partnership. Although there are nationwide models out there that make predictions for Colorado, the models that we are using were created with real-time Colorado data that many outside organizations do not have. We are certain our peak has not hit, and we are confident our models better illustrate the situation in Colorado. And Dr. Rachel Herlihy, our state epidemiologist, will give us an update on the models and discuss this more. So I'll turn it over to Rachel.
Thank you very much. We know that news reports are circulating that show Colorado has hit the peak of cases. In Colorado, we are relying on the best data we have specifically for Colorado. Our data show that with social distancing, the spread of COVID-19 has definitely slowed in Colorado, but case counts are still increasing. Our local models show that our peak in cases depends on how much social distancing we have achieved. And because of the delay from implementation of social distancing strategies to the time the impact of those strategies is observed, it is still too soon to know for us to know that precisely. We'd like to emphasize that we place greater trust in the models from the Colorado School of Public Health and the University of Colorado partners. This is because these models are based on Colorado data and assumptions that we believe best apply to Colorado, not national assumptions. But Coloradans are making a difference. We know this because traffic data, next slide, as shown in this figure, tell us that there are about half the usual number of cars on the road now than there were 4 weeks ago. There are half as many people traveling for retail or recreation reasons, and almost 40% fewer people traveling to their workplaces. We see a 13% increase in people staying at home. Public health data show us that disease is spreading more slowly in Colorado than it was a month ago. Without your sacrifices, we would have seen exponential growth in the number of cases in Colorado. Next slide. One way we are tracking the slowing spread of COVID-19 in Colorado is by measuring the doubling time. This is the time it takes for the number of infections in Colorado to double. This figure shows our cumulative case counts in Colorado and our average doubling time. In early March, cases in Colorado were doubling every 2 days. In the last week, that number has slowed to every 5 or 6 days. This is progress and shows the impact of social distancing. Our data and the modeling data being led by the Colorado School of Public Health show us that the early social distancing strategies, canceling mass gatherings and closing bars and schools, have slowed the spread of COVID-19 in Colorado. We estimate that those strategies have achieved approximately 45% social distancing, reduced the interaction of people in the state by about 45%. Next slide. This figure shows you when those earlier social distancing strategies, things like closing bars and restaurants, school closures, and cancellations of mass gatherings were put in place in blue. We refer to that as phase 1 of social distancing. It started in mid-March, but because of the time it takes for people to be exposed to the virus to develop symptoms, to then get tested, and then get reported to public health, it takes time for us to start measuring the impact of those policies. Here you see that we started seeing the impact of that first phase during last week. For phase 2 of social distancing, the governor's stay-at-home order, We expect to start seeing the impact on reported cases in the next few days. We anticipate that we may see that 60 to 80% social distancing has been achieved. Next slide. This next figure comes from our modeling data. The red line shows the daily number of cases that would have occurred in the state without social distancing. The green line shows our daily case count, as we have achieved with approximately 45% social distancing in place. Because of our early social distancing strategies, an estimated 1,200 cases of COVID-19 have been prevented in Colorado. Next slide. The next several figures shows what we predict may happen once we start seeing the impact of the stay-at-home order in the next few days. Each line here and color represents different levels of social distancing. The lines diverge on March 26th when the stay-at-home order went into effect. We believe the stay-at-home order will achieve 60 to 80% social distancing, as shown by the flattened purple, blue, and orange lines. Next slide. One of the main priorities with social distancing is to flatten the curve enough to prevent our healthcare system from being overwhelmed. This slide shows the number of ICU beds we anticipate will be needed on a daily basis in Colorado. The dotted horizontal line shows the current number of available ICU beds in Colorado. If the number of available ICU beds is surpassed, Coloradans may not have access to the life-saving treatment they need. We would again believe the stay-at-home order will achieve 60 to 80% social distancing, so the purple, blue, and orange line. If we have achieved 70 to 80% social distancing, you'll see that we stay below the current ICU bed capacity, as shown by the dotted horizontal line. If we have achieved 60% social distancing, we surpass the currently available number of ICU beds in Colorado in mid-May. This is why social distancing is so important. It's important for everyone to take these recommendations seriously and to take this virus seriously. We are social distancing to save lives. If we don't take this seriously, we will continue to see an increase in cases and a tragic loss of life. We will see our hospitals become overwhelmed and our healthcare system having to make tough decisions. But if Coloradans redouble their efforts to stay home, if we wear masks, if we follow these recommendations, we can help people get the treatment they need and save lives. Now is not the time to back off. Now is the time to pat ourselves on the back and keep doing what we're doing. Let's keep it up. I would like to now introduce Dr. Eric France, Chief Medical Officer for the Colorado Department of Public Health Environment. He will talk about the state's new crisis standards of care and what we can all do to slow the spread of COVID-19. Dr. France?
Thank you, Rachel. Very interesting data. I'm Dr. Eric France. Thank you all for joining us this afternoon. I think many of you know that yesterday the governor's Expert Emergency Epidemic Response Committee voted to update our crisis standards of care guidelines, taking into consideration the pandemic of COVID-19. Crisis standards of care are guidelines for how medical communities should allocate scarce resources like ventilators, ICU beds, personal protective equipment, emergency medicine services like ambulance trips, and we call on crisis standards of care during times of emergency, such as we have now with our pandemic. The governor will enact a public health emergency, and within that, our crisis standards of care are authorized, allowing the provision of medical care at levels of quality that would ordinarily be less than optimal. Because of this pandemic, we can expect 30 to 40% of Coloradans to become infected over the coming months. About 5% of those infected will become hospitalized. And of those hospitalized, 40% of them may be in the ICU. And more than half of those in the intensive care unit will need to be on a ventilator. With that kind of burden facing us, we may run the risk of having scarce healthcare resources to take care of our population. And this is why crisis standards of care are needed. How do you do this? Well, we recommend and are expecting that every hospital or health system will have a crisis standard of care triage team at their site or in their system. And they will be the ones that will be making these difficult decisions. They will be blinded to any irrelevant information, such as race or ethnicity, nationality, or other things that don't really predict your healthcare outcomes. And these triage teams will not include those doctors and nurses who are taking care of patients on the front line. It's very important that they stay unbiased and separate from frontline care. How will they do this work? Well, we're proposing that there are 4 tiers of decision making. The first tier will be a scoring system, and this scoring system will look at both the severity of the acute illness today, so how ill is this person and what is their chances of survival over the upcoming weeks. They will score the acuteness of the illness, and then they will look also to any chronic medical conditions that the patient may have that might be life-limiting over the next 6 months to a year or so. Scoring both of those aspects, the acute illness and chronic conditions, are then added into a final score. And final scores are then used as they make decisions on allocation. There may be times, however, that there will be ties between patients at this first tier. And so then we move on to the second tier. The second tier has a few more conditions for consideration. Pediatric patients, we feel that in general, our communities and societies feel that children should have an opportunity for a full life. First responders and healthcare workers, where we know their services will be needed to provide care for the rest of us during this time, should be elevated. If after looking to tier 2, there's still a tie, we move into tier 3. Tier 3 brings other special considerations, such as pregnancy, the number of life years left. So comparing a 27-year-old versus a 77-year-old would be something to be considering. And so at the tier 2, we have these other potential special considerations. Finally, at tier 4, if you find that you've actually tied all the way to that third tier, the 4th tier would be to do a random allocation to choose how to use these scarce resources. It's clear that this is a difficult time. Indeed, I would say that we're in crisis, and the standards of care today, particularly for the use of personal protective equipment, or PPE, needs to be considered in crisis standard of care. Our physicians are having to think about reusing masks and other material that they would normally, in normal times, not have to reuse. Because of this, we will be enacting crisis standards of care, particularly for personal protective equipment, in the coming days. These conversations are not easy, but it's very important that they happen now. They happen before we're in the midst of difficult decision-making of the pandemic. And so I'm very pleased that these crises standards of care were recommended and approved just yesterday. I'm also very proud of all the work that's going on to make sure that this pandemic does not spread. Remember, the work you're doing every day to stay physically distant from others is helping to mean that our future physicians and nurses will not be overwhelmed in their hospital setting in the coming weeks. So thank you. I hope you feel proud for what you've done, and that you'll keep up the effort to minimize the spread of this coronavirus and reduce the illness. And with that, we will turn it over to our question and answers section.
All right, yes, so right now we will begin taking questions and answers. So again, we have on the line for us Scott Bookman, Incident Commander of CDPHE, Dr. Eric France, the Chief Medical Officer of CDPHE, Dr. Rachel Herlihy, State Epidemiologist, and Jill Hunsaker-Ryan, Executive Director of CDPHE. And if you chat in a question, please include your name and the media outlet that you are with. I will go ahead and read the questions out. If there's a duplicate, I will acknowledge that we have received it, and then we'll go ahead on to the next question. Okay. This question is from Steve Stager. Is CDPHE considering the IHME model, which showed a dramatic reduction in deaths in Colorado's forecast? What factors are involved in selecting the models?
This is Rachel. I'll take that question. So the IHME model and other models are certainly models that we are considering here in the state. I think it's important to recognize that the best fit of the data and the best application of these models is going to be based on the data we think is most relevant to Colorado. And as I said in the beginning, we feel like the data that is being used to populate the model being developed by the School of Public Health, we feel like is probably the best model for Colorado right now, because it's using assumptions that we believe to be true for Colorado. It's using Colorado data. So that model in particular, we think is our best predictor right now, but we are certainly considering other models. With the IHME model in particular, we are aware of some limitations and some assumptions that are different from the assumptions we are using here in the state right now with our modeling efforts.
This next question is from Mark Craddock with the World Journal newspaper. It's a two-part question. According to one of the critical standards of care documents posted Sunday night on the CDPHE website, cscactivation.geerc approved PDF, when a county, region, healthcare provider, healthcare facility, or other healthcare entity enters a crisis level of care, as defined in Section B, it may adopt the relevant crisis standards of care described in this plan. But there is no Section B posted in the documents, thus no specific definition we can see for a crisis level of care. Can you provide a more granular definition of a crisis level of care as articulated in the CSC? Is there a specific numbers-based trigger? That's the first part of the question. Oh, pardon. 1 second. I think
my apologies. I had myself muted. Thank you for the question. We'll look over the document to be sure that any references are appropriately numbered. There are a variety of different triggers that can be set, and there'll be an ongoing, I think, conversation, because that while there may be some overall triggers, so for instance, for PPE, I think the trigger is clear that multiple reports coming across hospital care systems of having to reuse equipment in ways that wouldn't be considered the traditional standard of care is enough for us to enact that trigger. When it comes to, for instance, questions about ventilators use, if a hospital is finding that their ventilators are in short supply based on the patients that they have coming in, there'll be conversations with our centralized unified command center to better understand where other hospital beds are, where other ventilators may be. And I think it's in those conversations that the determination would be that a crisis would be needed in a local setting. If instead it became more obvious that this was a broad issue across multiple care delivery settings, then I imagine that we would then institute a statewide activation of the standard of care.
Part two of this question is, and since a disaster declaration from the governor is made in response to local requests, is it right to assume that there may be regions in the state where CSC will apply and others where it will not, depending on the local circumstances? Or does CSC go into effect statewide upon the governor's executive order and the CDPHE's chief?
Again, maybe using the PPE as an example, there could be some settings where the PPE supply is appropriate, and so the call out for a crisis standard is less relevant. Physicians will always practice to the standard of care based on the conditions that they have available to them. And so while there could be local enactments of the standards of care, it will always depend on what's needed at that time, doing the best for those patients by those providers. I would say too that there's a need for liability coverage for healthcare providers and other institutions as they practice in a manner that is consistent with a state of crisis. And enacting them will also help protect any liability issues for the providers.
This next question is from Ellis Arnold at Colorado Community Media. This weekend, CDPHE released modeling data for the epidemic curve that shows the peak of infections could be anywhere from May to throughout the summer. In what month does CDPHE think the peak will likely be, and when would it want the peak to ideally be?
Right, so a lot of the predictions on when Colorado will peak really depend on the level of social distancing that have been achieved by the governor's stay-at-home order. And as I mentioned previously, it's really going to be a couple of days until we have a clearer sense of whether that social distancing that was achieved was around 60% or perhaps closer to 80%. And so based on the models we have, it could be anywhere from May until later in the summer. And we hope to narrow down on that in the next couple of days and have a better sense of that. To best prepare our healthcare system and ensure we have adequate PPE, ventilators, supplies, hospital beds. Ideally, we would like to see that curve flattened and that peak later so that our system is best prepared.
This question is from Marianne Goodland with Colorado Politics. Can you address the dramatic decline in the IHME models that show Colorado is now past its peak?
Yeah, so there certainly are differences between the IHME model and the model that was developed here in Colorado with the School of Public Health and the university. Some of the big differences between those two models are the estimates of the number of ventilators that are needed for patients. So one of the estimates we're using here in Colorado, based on Colorado data, is that a large percentage of patients who require ICU care need ventilators. That is different from assumptions that are in the IHME model. Very similarly, there are differences in the IHME model and the Colorado model in the levels of social distancing that are achieved. The IHME model was really built off of assumptions from Wuhan, China. And we feel that those assumptions are really probably not the same as the assumptions that we're seeing here in Colorado and the data we're seeing here in Colorado. When you look at the success or the ability to implement social distancing strategies, there's big differences between those strategies being applied in Wuhan, China, during their epidemic compared to how those strategies are being implemented here in Colorado. And so those are really two major reasons that we see some pretty significant differences between the IHME model and the Colorado model.
This question is from Ellis Arnold at Colorado Community Media. Is the statewide stay-at-home order in its current form the broadest or most restrictive action the state could take regarding social distancing? Is the state looking at closing more types of businesses, giving people less ability to leave home, etc.?
Hi, it's Jill Ryan, and I'll take that. So we are in the process of evaluating the level of success produced by the stay-at-home order. And of course, as I mentioned, our North Star is to keep the number of cases that need an ICU bed below what hospitals are able to offer in Colorado, because we know that 100% of people that need a ventilator and don't get one will not survive. So the School of Public Health is helping us to model that. And if we need to do something differently around stay-at-home order, we certainly can. China, of course, has more strict social distancing. If your question was, could we be more strict? That's probably on the extreme end of the spectrum. But certainly when we make these decisions in Colorado, the governor takes into account personal freedom, the economic consequences, and then trying to balance all that in the context of hospital capacity.
This next question is from Steve Stager at 9 News. Does the existence of the IHME model complicate CDPHE's response? Does the state consider the IHME model in the forecasting of this pandemic in the state?
This is Rachel. I'll take this question. So it's useful to have multiple models to look at. So we have our Colorado model, we have the IHME model, and there's many other models that we are evaluating and considering as we're doing planning here in the state. But as I said previously, we really think it's probably best to use a model that is built off of Colorado's data and is using assumptions that we are seeing to be true here in Colorado.
This next question is from Jim Anderson with the Associated Press. How does Colorado compile its PPE and ventilator request totals of the federal government? What are they based on? The requests have been larger than some states such as Pennsylvania. And has FEMA provided clear guidance on how the state is supposed to make its request?
Scott, I'm wondering if you'll jump in there. That'd be perfect.
Sure. This is Scott Bookman. So we are continuing to evaluate how we are compiling those requests and put them in. We are using PPE burn rate calculators now to try to determine the total amount of PPE that we'll need each month. That will have to include the alternate care sites that we're trying to stand up as well. And then we will submit updated requests through FEMA or try to just procure that PPE on the open market as well.
This question is from Jeremy Hohola at 9 News. Our viewers continue to ask us about recovery numbers. Can you explain in detail why CDPHE is not releasing any data related to recovery? What about those who were admitted to hospitals but then were released?
Jill, would you like me to take that question?
Yes, please, Rachel.
Okay, great. So I think it might be helpful to understand a little bit about our epidemiology investigation processes. So typically, what happens when the state is notified of a case is we work with our local public health partners to contact that individual, interview that individual during the course of their illness to better understand their symptoms, when their symptoms started, and then ask questions about whether or not someone needed to be hospitalized, those types of things. And so those interviews are typically done once during the course of their illness. And so we don't routinely collect data at the end of their illness about outcomes. So there's some challenges in trying to get recovery data, but we are exploring ways to get some of that data, as mentioned in the question, from hospitals. So looking into whether or not we might be able to get hospital discharge data that could tell us a little bit more about the percentage of patients that are admitted to hospitals with COVID-19 that are then discharged back to home after their infection.
This next question is from Corey H. Jones with CPR News. What else can you do to slow down the outbreaks at elder care facilities?
I could take that. Do you want to take that, Dr. Burns?
Well, I'll say that there's certainly a lot of work underway to both do the contact tracing and quarantine, isolation, identification to work up the outbreaks themselves. We also have a division here at the Department of Public Health and Environment that focuses on the licensing of hospitals, nursing homes, long-term care facilities. And for the last number of weeks, they've been very focused on doing on-site visits, particularly looking at infection control and making sure that these facilities are learning and where they should be when it comes to their practices. We've also looked up over the last 3 years for any of the facilities that may have been flagged in the past for a potential violation on infection control and focus some of our efforts there. And so a lot of the work is using our surveyors to see what can we help, how can we show up as a partner and technical advisor for the nursing homes themselves so that these outbreaks don't happen, whether it's nursing home, clinic, jail, prison, anywhere we have a higher risk for the citizens.
This question is from Carlos Moreno with Univision. I would like to know what can we as Colorado residents expect this week? What are the estimates of death from coronavirus in our state? Could the health system collapse?
Sounds like you want us to look into the magic ball and predict what's happening. Maybe the best way of predicting is to look how things have been going. We've certainly seen that the cases every day seem to be increasing, but not at an exponential rate, as Dr. Herlihy described. We've also seen cases potentially plateauing in the hospital, and we're hoping that this is a trend that will continue for the week coming forward. It would be a bright light, essentially pointing to all the physical distancing work that's happened over the prior weeks as now being reflected in the number of cases and the number of hospitalizations we see. We looked at other places in the country where there is potentially some slowing down of the infection rate and think of ourselves as maybe just a week behind them. So we're hopeful, and we're hoping that the data we'll see will continue to be in an optimistic direction. I would say that the data we see now is certainly optimistic. It's not an overwhelming exponential growth at this time.
We received a question from Jensen Worley with the Denver Business Journal asking if the modeling data Colorado is using, when would CDPHE consider the state's new peak period? I believe we've answered that already, so thank you. This question is from Jesse Paul with the Colorado Sun. Can you provide more specific guidance about the social distancing etiquette while outdoors? Should people wear masks while exercising outside? Can people take walks with someone who is not living in their household? Can neighbors hang out together outside if they stay 6 to 10 feet apart?
So I'll answer this by saying, in general, yes, we want you to wear a mask when you're outside, but there's an element of common sense, of course. If you're unable to breathe well enough when you're going jogging and you're not jogging in a big pack of people, for example. But we really do want to promote this as the norm. Please wear these when you're running errands. In terms of hanging out with neighbors, we would recommend that if people are hanging out outside with their neighbors and interacting, that they are wearing the masks, even if they are 6 feet apart. So people can go to the CDC website, and they have additional guidelines on cloth face coverings, or if you check out the Colorado Mask Project, which is also selling masks online.
All right, so I think we have time for a couple of more questions. This one is from Mary Shin with the Colorado Springs Gazette. Are coronavirus tests becoming more available? If not, can you say when you expect tests to become more available?
I'd be happy to take that. I would say that we do see a nice expansion of coronavirus tests in the commercial labs and commercial partners. Certainly a number of institutions across the state, like University of Colorado, National Jewish Hospital, Children's Hospital, I believe, Kaiser Permanente, are all building out their own testing. If we look at our daily tests, we're doing about 1,800 to 2,000 a day now. And at this point, probably 3/4 of those are done through our commercial partners rather than at the state lab. In the meantime, the state lab is also expanding from a baseline of 140 to a current capability of between 500 and 800, with plans to expand that up to 1,500 a day over the next month. We know that high levels of testing will be important as we get to the other side of this pandemic, and we need to continue to track the infection in the community, isolate and quarantine to control it once we start opening up some of our physical distancing.
All right, and then this will be the last question. This is from John Ingold at the Colorado Sun. When you say you expect 30 to 40% of the state to become infected, are there any populations you expect to be particularly hard hit? Will infection rates be higher among first responders, medical workers, grocery store workers, and others who can't stay home?
Yeah, good questions. Certainly, infection rates are tightly related to being exposed. And so persons whose work has them exposed will likely, unless they're wearing the right personal protective equipment, be at higher risk of becoming exposed. So we know too that with respiratory illnesses in general, children and young adults are more likely to spread it because of their congregating at schools and universities and other settings. So there will likely be these differential spread of coronavirus as the weeks go forward. I imagine that our lives will be changed over the next many months as we try and live in a society where physical distancing will be important while we try and maintain our social connections.
All right. Well, thank you all very much for joining us here today